Welcome to our live webinar titled Understanding GvHD. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMD-SIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation. To submit a question or comment, open the Q&A window on the lower part of your screen, type your question in the small text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do 2 things to help us manage incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Catherine Lee. Dr. Lee is an associate professor of medicine in the Division of Hematology Bone Marrow Transplant at the Huntsman Cancer Center, University of Utah. Her clinical expertise is in blood and marrow transplantation, or BMT, and cellular therapy. She specializes in autologous and allogenic hematopoietic cell transplants for the treatment of malignant and benign hematologic diseases in adult patients. She also directs the clinical cellular therapy program and provides both standard of care cellular therapy treatments and those being tested in clinical trials. Furthermore, she leads the chronic graft versus host disease long-term follow-up program for patients who have received hematopoietic cell transplantation or other immune cellular therapies. This program is designed to monitor the health and quality of life of patients after transplant and also provides medical care specific to patients with chronic GvHD and late effects of hematopoietic cell transplantation or other cellular therapies. Dr. Lee is also the local principal investigator for clinical trials surrounding CAR T cell therapy, post-transplant maintenance strategies to prevent AML relapse, and novel conditioning regimens for MDS AML. With that said, welcome, Dr. Lee.
Thank you, Alice. Thank you for that very kind introduction. Hello, everyone. My name is Dr. Catherine Lee, and I am a bone marrow transplant physician for adults at the University of Utah Transplantation and Cellular Therapy Program at the Huntsman Cancer Institute and Primary Children's Hospital. That's a really long title, but we are located at the University of Utah in Salt Lake City, Utah. I've been here for a little over 6 years and have transplanted many adults. And from my experience, seeing some of the complications that can develop, such as what we're speaking about today, graft versus host disease, developed with my colleagues, specialized survivorship in graft versus host disease clinic and program to help deliver specialized care to patients who experience graft versus host disease and other complications of transplant. So I want to thank you and I applaud you for taking the time and effort today to listen to me on the internet, so that I can give you a little bit more knowledge and empower you with knowledge so that you can understand what this is and kind of take active participation in your healthcare. So I hope you enjoy today's webinar, and please feel free to submit your questions in. This are my disclosures. I have consulted for Jazz Pharmaceuticals, Fresenius Kabi. I participated on advisory boards, and I currently have research funding from Insight. So just to start off with a little bit of basic 101 knowledge of what transplant is. So when we talk about an allogeneic transplant or a donor transplant, a transplant from someone who is not yourself, what we're essentially trying to do is to bring cells in, healthy blood and immune cells from the donor into the patient who may have a hematologic disease. It could be aplastic anemia, it could be myelodysplastic syndrome, it could be leukemia, or any other type of hematologic cancers. And what we try to do by putting a donor's healthy immune system is that we use their immune cells as a way to eradicate the blood disease and to act as sort of permanent soldiers, if you will, to help prevent the blood cancer from coming back. For patients who don't necessarily have a blood cancer, but have a blood disorder such as aplastic anemia or other type of non-malignant bone marrow failure syndrome, what we're really trying to do with the transplant is to reestablish a normal, again, immune and a blood system, but we don't necessarily need the donor cells to eradicate a cancer. It's really just to establish a healthy immune and blood system. So for patients who we're trying to treat and cure a cancer, what the donor cells do, that they're called the graft cells is what comes from the donor, they mediate a graft versus tumor effect. So that's the donor cells of the graft fighting the cancer. At the same time, though, these donor cells can cause what is called graft versus host disease. So the tumor cells see some of the normal tissues. What they usually do is try to fight the cancer cells is what we want them to do, but sometimes they see the normal healthy tissue that are not cancerous as also foreign and causes graft versus host disease. So essentially what it is, it's an immune attack of the donor immune cells against the recipient, the patient's own tissue, that ultimately leads to quite a bit of inflammation and injury to the patient's tissue. And sometimes the tissues, because of all the inflammation and sort of the inability to repair itself, the tissue can't heal well, and in some cases can develop into fibrosis or scar tissue. So why is GvHD important? Well, I'm going to show some slides from the CIBMTR, which stands for the Center of International Blood and Marrow Transplant Research. This is the mother hub research center for all the transplants that are done in the United States and internationally. And each transplant center is required to give data from each of the patients that they transplanted to this research center so that physicians and scientists can understand what transplant is doing to our patients, how it's helping, how it might be negatively affecting patients. So this is some data regarding graft versus host disease. In general, when we look at the literature, graft versus host disease, the incidence, it's been reported that it can occur in up to 9 to 50% of patients. But death due to graft versus host disease is also very important. It's actually one of the leading causes of death, not related to the cancer itself from coming back, or what we call relapse. So in this slide is a pie graph showing causes of death after having a match-related donor transplant among adults. So these are adult patients who had a matched sibling. And if we look at the color coding here, this dark blue, which represents relapse or the primary disease coming back, is the highest cause of death in the first 100 days of transplant and beyond 100 days of transplant. But if we look at these other reasons of cause of death, we see that GvHD, which is sort of in this pink beige color pie slice here, represents 13% of deaths that occurred before 100 days after transplant, and here 13% again, the cause of death occurring in patients after the 100 days of transplant. The other causes of death are patients losing their graft or having infection. And the smaller percentages are due to other reasons, bleeding or unknown. And after the first 100 days, again, infections and organ injury are other common causes of death. If we look at causes of death in adults who received a transplant from an unrelated donor, so someone who's not a family member, we also see that GvHD, again in the peach beige slice here, represents quite a bit percent of cause of death in the first 100 days and represents about 11% of cause of death after the first 100 days. And then lastly, if we look at haploidentical donor transplant, so that is a transplant from a family member who is half matched. So it could be a half matched sibling, someone who's 50% matched or more, or a sibling or a parent or a child, a half matched family donor. We see that GvHD is still a cause of death, but it is a little bit lower compared to having a match-related donor or having a matched unrelated donor. So it represents 8% of cause of death here within 100 days of transplant and beyond 100 days of transplant. So this is important. So GvHD is an important problem that we're still trying to prevent and trying to treat successfully. And so when we traditionally talk about GvHD, we split it into two categories called acute GvHD or chronic GvHD. And traditionally, historically, the way we would used to categorize it would be based on when the GvHD presented. So typically, acute GvHD would happen in the first 100 days of transplant, and chronic GvHD would happen after the first 100 days of transplant, most commonly occurring at 6 months and all the way even up to the first 2 years after transplant. We now better characterize acute versus chronic GvHD dependent on the presentation or the features that the patient has, but they typically still, fall within a time frame. So going back to acute GvHD, it generally presents within the first 100 days, and it has a really strong inflammatory component, more than a fibrotic component that we see in the chronic GvHD setting. So when we say inflammatory, we see quite a bit of skin rashes, typically gut involvement, the stomach can be involved, or the colon, the small intestine, the large intestine, and sometimes we can see the liver involved. When we talk about chronic GvHD, it's less of an inflammatory picture, but more of an autoimmune and has features of fibrosis. So if any of you are familiar with other types of autoimmune diseases like lupus or rheumatoid arthritis, where the patient's own immune system attacks their own self, this is very similar in chronic GvHD. And in chronic GvHD, we can see more organs involved in this syndrome. The donor cells, which are now the patient cells, can attack the skin, the subcutaneous tissue underneath the skin, the mouth, the eyes, the lungs, as well as the GI tract, the gastrointestinal tract, which includes the stomach or the small intestine and the large intestine, the liver and the joints. And again, sort of the typical presentation of this is fibrosis, scar tissue. And when we go into the biology of acute GvHD, you can see that it looks quite complicated. This is a very busy slide, so I'm just going to try to summarize it for you. So if we look at sort of the first step of how GvHD occurs in the acute setting, this Roman numeral 1, we see that tissue is initially damaged by the conditioning regimen that we give to the patient. So it's, some patients can receive a little bit of a radiation or a lot of a radiation as part of the pre-transplant conditioning regimen. And the purpose of this conditioning regimen is to kill any lingering cancer cells that may be still involved, and as well to allow the donor cells to come into the patient and graft. So it is an important part of the transplant process, and we can't ignore it. But one of the side effects of this conditioning regimen is that it can cause some injury and damage to the organ. In this slide, we're looking particularly at the small intestinal cells. And so when the tissue is injured, it releases signal molecules, danger molecules representing, oh, hey, we've been exposed to this. Our tissue is injured. We need some immune response to this, right? And so this activates the immune cells that have come in from the donor. The T cells are activated, which then see some of these proteins released by the injured tissue as sometimes foreign, and it stimulates this cascade. It activates the T cells to kind of try to repair the injury and to sort of attack the cells that might be causing the injury. And this leads to more injury of the tissue cells and to cell death, which can also lead to death of the target tissue. So this whole cascade is sort of leads to a lot of inflammation because there are a lot of molecules and proteins that are released that kind of enhance this inflammatory cascade. So risk factors for acute GvHD include how well the donor and the patient are matched at the HLA typing level. And this is something that the bone marrow transplant, your bone marrow transplant physician can explain to you when we talk about HLA matching and finding that ideal donor. So patients who are not perfectly matched at the HLA that we're interested have a higher risk of developing GvHD. As well, we know that sex mismatch between the donor and recipient is a risk factor for GvHD. So scientists have seen that patients who receive particularly male patients who have a female donor are at a higher risk of developing GvHD. The conditioning intensity, that's how high we make the chemo intensity doses, or if we use very high irradiation doses as part of the transplant conditioning regimen. The intensity of the regimen, if it's a much more intense regimen, can also increase the risk of GvHD. The prevention medications that we use to try to prevent GvHD can sometimes lower the risk, or sometimes not as well as some other regimens lead to the GvHD forming. And then the last bullet here is the graft source. So typically when we do a transplant, we can choose from a bone marrow source, a peripheral blood graft source, or a cord blood source. And we know from studies that having a peripheral blood source from the donors leads to a higher risk of developing GvHD compared to a bone marrow or a cord blood source. So I'm just listing these here. So these are some things that you could ask your transplant physician to explain in more detail. So I mentioned that GvHD prophylaxis regimens, prevention regimens, we start this when we start the conditioning chemotherapy or radiation to help prevent GvHD from occurring. The best strategy is still not known. There's actually very large studies going on right now to comparing different prevention regimens to see which is the best at preventing GvHD. But these are some of the common regimens that we use: cyclosporine methotrexate, or tacrolimus methotrexate, sirolimus or tacrolimus, mycophenolate mofetil, otherwise known as MMF, anti-T-cell antibody, otherwise known as ATG. And some centers use a T-cell depleted transplant. So what they do is either with a medication or before they infuse the donor cells into the patient, they will actually try to remove all the T cells that they can from the donor cells before they're infused into the patient to try to reduce the risk of graft versus host disease. So now I'm just going to move on to some of the clinical symptoms and signs of graft versus host disease. As I mentioned in a prior slide, in the acute form of graft versus host disease, typically the organs are affected are the skin, the intestinal tract, and the liver. And so when GvHD happens in the skin, most of the time it shows it results in this red, angry rash. This is what we call the inflammatory rash. So it often starts off as having dry, itchy skin. So this is the word pruritic, itchy skin. It can be quite sensitive. The skin can be quite sensitive. It can feel like a sunburn. The feeling of having sensitive skin, itchiness, red, and the redness or the inflammation can just be in localized spots, such as on the hands or the feet, or it could be sort of a full-on body sunburn-looking appearance. Sometimes in severe cases, from sort of how inflamed the skin is, the skin can develop bullae or vesicles or sort of blister-looking lesions, and sometimes the skin can peel off. Here's another example of the GvHD just affecting the palms and the soles of the feet. And then the GvHD, acute GvHD, can affect the intestinal tract. So this could be the upper or the lower intestinal tract. If it affects the lower intestinal tract, usually many patients will report quite a bit of diarrhea every day, watery diarrhea, more than 5 times a day. It may be associated with abdominal cramps. It may be associated with a little bit of bleeding. Some patients will notice blood in their stool. And sometimes the intestines can be very upset that they become a little bit paralyzed and develop an ileus. So they're not, the intestines are not sort of making sort of their natural waveform, and they become a little bit paralyzed, and patients can feel a little bit bloated. When the GvHD affects the upper intestinal tract, usually the stomach, most patients will complain about quite a bit of nausea, not having an appetite, having stomach pain. But typically when only the stomach is involved, we don't see much diarrhea. All right. And then when we think about these symptoms, we have to think about other possible diagnoses instead of GvHD that could cause these symptoms. So when patients are presenting with diarrhea, mainly diarrhea, we have to make sure there's no infection involved, such as C. difficile or some viruses. We have to see what antibiotics patients are on, because sometimes antibiotics can cause a lot of diarrhea, and some medications can also cause a lot of diarrhea, such as Cellcept, which is one of the GvHD prevention medications that I mentioned. When we talk about the upper GI tract, particularly the stomach involvement, and patients who present with nausea, again, we have to rule out infections. We have to see whether maybe some of the chemotherapy in itself that the patient received as part of the transplant conditioning regimen is causing the nausea and vomiting. And so those are the usual differential diagnoses. Okay, so when acute GvHD occurs in the liver, it usually will happen if there's skin or gastrointestinal involvement of GvHD. But sometimes it can present on its own, only the liver will be involved. And I will say it occurs less frequently in the liver than it does in the skin and in the gastrointestinal tract. So when GvHD does affect the liver, usually we start suspecting GvHD when we start seeing elevation in some of the liver blood work. So such as the AST, the ALT, the alkaline phosphatase, the bilirubin particularly. Okay, and that's due to increased bile or cholestasis. When the bilirubin gets to a very high level, some patients will actually start showing some yellowing of the skin, which is otherwise known as jaundice. And then when the liver is injured and can't work properly, sometimes we see some patients develop fluid retention. So they might start noticing their ankles swell or their bellies feel more bloated because they're starting to develop fluid in the belly. The decision to treat is based mainly above clinical evaluation. So if the physician feels very strongly based on the symptoms that a patient likely has acute GvHD, we will treat without confirmation of a tissue biopsy. Otherwise, in some of these borderline cases where we need to make sure there isn't some other cause of the symptoms going on, we will pursue biopsy of the skin, of the gut, or the liver. And let me just go back to the slide. So there are different ways of doing that. When we want to do a skin biopsy, oftentimes we have this small little tool on site, and it's what we call a punch biopsy, and we can just grab a small piece of skin and we'll send that off to pathology to take a look under the microscope if we see GvHD. If we need a stomach or a colon biopsy, usually we have our gastroenterologist colleagues involved. Those are the doctors who specialize in the gastrointestinal tract. And they'll usually take a patient to an endoscopy or a colonoscopy. That's where we put a camera either through the esophagus if we're trying to get into the stomach, or through the rectum if we're trying to get into the colon, to visualize the tissue and to take tissue samples there. And patients are usually under sedation when they're undergoing this procedure. And if we need to do a liver biopsy, there are a couple of ways to do that. Some places or some doctors will get tissue biopsy by actually putting a needle through the abdominal cavity, so through the skin. And at other places, or the alternative way of getting a liver biopsy is actually to thread a needle through one of the main blood vessels that leads down into the liver, and we would get a tissue biopsy that way. And patients are also under sedation when that occurs. Okay, so once we suspect and diagnose acute GvHD, we follow this grading system to determine how severe it is. And determining how severe the GvHD is important to determining how we're going to manage the GvHD. So this is what we call the MAGIC criteria. It's a modification of the historical Glucksberg grading. And as you can see here, we have different columns for skin, liver, upper gastrointestinal tract, and lower gastrointestinal tract. And depending on the features of each of the organs involved, we give it a certain stage. And then these stage of the different organs are calculated to give an overall grade. And depending on the overall grade, that will determine how we treat the GvHD. So grade 0 means no organs involved. Grade 1 is what we usually consider mild acute GvHD. Grade 2 is where we would start treating with strong medications to treat the GvHD. And grade 3 and 4 are more severe stages of acute GvHD. So here's just an overview of the treatment for acute GvHD. For mild grade GvHD, usually it just requires topical medicine. So medicines that are just focused on the skin and acts locally at the area that's impacted by the graft versus host disease. So sometimes for patients who present with just an isolated skin rash, we'll just use a cream, a steroid cream, or a tacrolimus cream to apply to that area, that local area. For patients who have just a little bit of nausea or very mild gut GvHD, we'll use pills called budesonide and beclomethasone, which are consist of steroid, but they just act at that site. When we get into more severe forms of acute GvHD, we need to give what we call systemic treatment. So these are medications that would work at sort of diffusely throughout the body. And so corticosteroids, high dose corticosteroids such as prednisone, salumedrol, dexamethasone, these are steroid names that you might have heard, are used as first-line treatment because steroids are anti-inflammatory medications. What they're used for is to help dampen that inflammatory component that's going on, the inflammation process. And so we use a very high dose, 2 milligrams per kilogram of body weight. And then we hope in the first 3 days of treatment that we see improvement. As well, most of our patients will still be on GvHD prevention medications during this time. And if there's no response, or if there's progression after 3 days of these high dose steroids, or if there's no response after 5 to 7 days, we call that patient steroid refractory. And then we need to move quickly onto the second line therapy so that we can abrogate or stop this inflammatory process quickly. There are several agents that different physicians will use, but the first FDA approved agent for steroid refractory GvHD just became available a couple of years ago, and it's called ruxolitinib. And this is the only FDA-approved agent for steroid refractory graft versus host disease. Okay, so now moving on to chronic graft versus host disease. If you remember from a prior slide, I described chronic graft versus host disease as a syndrome that typically occurs after the first 100 days of transplant, but more importantly, it shows up as a autoimmune problem, or a syndrome that's characterized by fibrosis. So in this scenario, usually patients will complain about dry eyes, dry mouth. Their lungs could be affected. They can still have skin rashes, but the joints can be affected. And I'll show some slides showing some of those signs. But the biology here is very complex, similar to acute GvHD. It's a polymorphic disease, meaning that it has many different presentations. So it's very hard to define one biologic path leading to chronic GvHD. What makes the problem of chronic GvHD a little bit more intense is that because chronic GvHD can happen anytime, usually in the first 2 years of after transplant, but it could happen after 2 years. Many of the patients are away from the transplant center when it does develop. And if patients don't know the signs of chronic GvHD, it may go untreated for a while. So this is the point of this webinar, is to give you all this knowledge so that you can be aware of the symptoms and signs of GvHD if they're happening, and you can contact your physician quickly and get treated quickly. For some patients, it requires multiple physicians with different expertise in different organs, because chronic GvHD can affect many different organs and requires very specialized care. So as I mentioned before, it's initially, it's sort of an inflammatory process, but due to poor tissue repair, the tissues then can develop scar tissue, which then involves the fibrotic pathways in chronic GvHD. So risk factors for chronic GvHD, the main risk factor that we know is that having prior acute GvHD elevates the risk of having chronic GvHD. We know that the older age of the patient is a risk factor for chronic GvHD. Again, HLA mismatch, the degree of mismatching between the patient and the donor is a risk factor. Female donor to male recipient, again, is a risk factor here. The use of peripheral blood stem cells and a high number of T cells from the donor into the patient. As I mentioned before, chronic GvHD can affect different organs as listed here. And now I'm going to move on and show some pictures of what chronic GvHD can look like. So here we see what we call sort of lichen planus features of the skin. So we see hyperpigmented or sort of reddish purplish patches of rashes that can occur diffusely over the skin. Here we have some hyperpigmentation. So after that acute red inflammatory appearance, these lesions can quiet down a little bit, and they typically they kind of brown down, they become hyperpigmented. Here the eyes are affected. We can see redness around the eyes. There's some inflammation. Sometimes the eyelids can get inflamed, and this is what we call blepharitis. Usually patients will report really just dry, gritty eyes, and oftentimes need to use eye drops to help keep their eyes moist. The lips and the mouth can be affected. So here we see some whitish stripling along the border of the lip. Okay, so it's kind of this, again, lichenoid changes. And inside the mouth, we also see these white Wickenheimer's changes. So again, white stripling, lichenoid changes inside the mouth here. When fibrosis is obvious, or sclerosis in the subcutaneous tissue and sometimes in the superficial overlying tissue, we can see dimpling in the skin. And so this is where scar tissue kind of sets in the underlying skin underlying skin and causes dimpling or rippling of the skin. When sclerosis becomes very severe, it can cause again the underlying tissue underneath the skin to adhere to the bone. So it creates this very rod-like looking appearance. So this would be severe sclerosis. And due to the fibrosis that developed under the skin and the scar tissue, some patients have a very difficult time having full range of movement in their joints in the skin. They often report feeling tightness of the skin or tightness of the joint. And so when we see these patients in the clinic, we ask them to do a set of maneuvers to help show us how severe the skin and the joints may be. So oftentimes we ask patients to do what we call a prayer sign, or we'll have them try to extend their forearms out to see whether patients can extend their arms out completely at 180 degrees. And then we'll also have patients try to elevate their arms just to see how their flexibility is at the shoulders and the triceps here. And lastly, chronic GvHD can also affect the hair and nails. So you can see here that some patients will have patchy hair loss, area of baldness. We see what we call nail dystrophy here. So some patients will lose their nails or have cracks in the nails. And we can try using some medications, some cyclosporin drops, some immunosuppressive therapies, but oftentimes I have not found that too successful. So the goals of treatment for patients who do develop graft versus host disease is to control the current symptoms, to prevent additional organ damage from the graft versus host disease, and while we're treating them, to minimize any treatment toxicity, avoid late effects of GvHD and from the treatments of GvHD, and maintain an anti-cancer effect. So what this means is making sure that the treatments that we're giving doesn't allow the original disease that we treated for, that we did the transplant for, to come back. So we want to make sure that we don't see any disease relapse. And so in the chronic GvHD setting, again, the first line of treatment are high-dose steroids. Here, usually we use high-dose steroids for quite a long time. Usually most patients are on high-dose steroids for a year, which in the long run, this isn't great. Prednisone and other high doses of corticosteroids are not great for other parts of the organ system because high-dose steroids can lead to weak bones. It can cause high blood pressures. It can cause high sugar levels. And so long-term use of high-dose steroids is not ideal for patients. The overall response rate to high-dose steroids is about 50%. So half of the patients will have a response over 2 to 3 years. Based on the data that we have, we know that at 6 months after starting treatment with steroids, less than 40% of patients are alive without malignancy and who are on lower doses of steroids and who don't need additional treatment for GvHD. So this tells you that about half of our patients need to go on to another line of therapy because the steroids aren't working optimally to treat the GvHD. So second line therapies that are available, we always try to recommend a clinical trial whenever possible. New drugs are being investigated to this day. And if we can find a drug that is better than steroids or better than other drugs already on the market, it's always a win for us, right? Let's see. I'd like to point out that there have been recently 3 recently approved FDA drugs for chronic GvHD. The first FDA approved drug, and again, this is in the setting of patients who have not responded adequately to steroids. So this is in the second line setting. The first FDA approved drug was ibrutinib. This came out a couple of years ago. And so for patients who don't respond to steroids, ibrutinib may be an option. It's a pill. Most recently was the FDA approval for ruxolitinib or Jakafi. and belumosudil or Rezurock. And ruxolitinib or Jakafi is approved for patients who have failed at least one line of therapy. So if patients fail steroids, they are now eligible to receive ruxolitinib, and this is also an oral pill. Belumosudil was FDA approved for patients who have failed at least 2 lines of prior therapies. So if someone has failed steroids and then failed either ibrutinib or ruxolitinib, they would now be eligible to receive belumosudil for their chronic GvHD. So this is really exciting. We have just started putting patients onto belumosudil and ruxolitinib on label, and we're really looking forward to seeing that the outcomes that we see in real world practice match that to the major clinical trials that were done with these agents. And so when we talk about chronic GvHD, as I mentioned before, for some patients, because of the number of organs involved or the type of organs involved, it requires a multidisciplinary approach to effectively treating chronic GvHD. For some patients, we may need to bring on the lung doctors to help manage some of the lung issues associated with lung GvHD. We work very closely with our skin doctor colleagues, the dermatologists, and our eye doctor colleagues, the ophthalmologists. We work very closely with physical therapy. We actually have a physical therapy who sits in our clinic to help bring personalized exercise programs to our patients with specific types of chronic GvHD. And lastly, what I want to make you aware of, I've alluded it before, is that some of the treatments of GvHD in itself, and some of the treatments that we use for GvHD can cause some what we call late effects or late complications down the road. And so patients who are on treatment for GvHD or who have GvHD, we are very vigilant about monitoring their heart health, their bone health. We're very vigilant in monitoring for any secondary cancers that can develop. And so these are aspects of your care that should definitely be discussed with your transplant physician. So in summary, acute and chronic GvHD is still a major complication after transplant, but we are understanding the biology better. Because we're understanding the biology better, we are testing and coming out with better therapeutics compared to the historical just steroids. And so participating in clinical trials is really important. And as well, what's really important is for all of you to understand the effects of GvHD and the treatments on your body, and for you to be active in your own healthcare. So with this, I'm going to complete my presentation, and we can take any questions. Thank you. Thank you for your attention.
Thank you, Dr. Lee. Our first question is from one of our participants today. This person has a sister and brother. Are the chances of this patient getting graft versus host lower if the brother is the donor? I'll read the whole question, and I may have to go back to parts of this. So are the chances of getting graft versus host lower if the brother is the donor? Would a sibling at a 50% match be better than an unrelated donor at 50% or higher match? And how about the old age donor? The twin brother is 69, the sister is 74. Are younger unrelated donors in their 40s or 50s a better match?
Okay, yeah, that's a great question. There are a few questions in one, and so I'll try to cover all of them. So in general, if the patient is male, we know that having a male donor, it can be preferable to having a female donor. The risk is lower. The risk of GvHD is lower with having a male donor if you have the options of picking between a male or female. But if there are no options and your donor is a female, that does not mean that you should throw away that female donor. But if you have the option of choosing between a male or female donor, yes, we would typically use the male donor. Now, in terms of a half-matched sibling versus a fully matched sibling and the age, So some of this, having a fully matched sibling lowers the risk of GvHD compared to having a matched unrelated donor. Now, some of these can be traded off by the type of GvHD prevention regimens that are being used. So this is a moving field right now, but generally, historically, yes, a fully matched sibling lowers the risk of having graft versus host disease. Now, the risk of graft versus host disease between a matched unrelated donor and a half matched sibling is pretty similar. And that's because there is something called post-transplant cyclophosphamide. It's a type of GvHD prevention regimen that is being used that has shown to be very effective in preventing chronic graft versus host disease in half-matched sibling transplants. This post-transplant cyclophosphamide looks to be really to be quite effective, and so some transplant centers are even moving this post-transplant cyclophosphamide regimen into the matched unrelated donor setting and the probably under clinical trial related donor setting. And so it's a moving target. And this is something that would have to be definitely discussed with your transplant physician a lot more, because every center is doing something a little bit different in terms of their GvHD prevention regimen. I hope I answered that fully. And if there are any further questions, please feel free to email me at the email address I posted on my first slide.
Yes, thank you, Dr. Lee. Another question. Is GvHD a lifelong condition?
For some patients, yes. For some patients, no. So for patients who, if we're talking about acute GvHD, our goal is to basically suppress it and stop the whole GvHD process quickly, and then it would not become a lifelong condition. When we're talking about lifelong condition, we're probably talking more about the chronic GvHD aspect. So for some patients, active chronic GvHD can be a lifelong issue. It's not, for those patients who don't respond well to first-line steroids, which is about 50% of the patients, those patients will have to go on to second-line, third-line, fourth-line regimens. Approximately, 30% of all of those patients who develop chronic GvHD may be on immunosuppression or treatment for a very long time. Some patients may have evidence of chronic GvHD, but it may not affect their ability to go to work or to participate in the things that they like doing. So for some patients, it can be a lifelong issue, but the severity of that can differ between patients.
Thank you. And then somewhat related, is there a timeline for developing GvHD? Can a patient still develop GvHD years out from a transplant?
Yeah, but it's not common. Most of the chronic GvHD that usually occurs in the first 2 years following transplant. So that's when we're talking about chronic, based on some of the studies that I've done and that we've seen. Usually the middle time when most patients develop some type of chronic GvHD is usually around 6 to 8 months after transplant, but it can happen, although most commonly happen in the first 2 years.
Thank you. Or do blood transfusions increase the likelihood of GvHD? Someone has had 53 blood transfusions since the diagnosis of aplastic anemia 3 years ago.
So in terms of the graft versus host disease, the type that I'm talking about, blood transfusions have never been associated or linked as a risk factor to acute and chronic GvHD of the organs.
Okay, thank you. Does the type of pre-transplant conditioning impact who will or will not develop GvHD, or may not develop GvHD?
Yes, so we know for patients who receive irradiation, there's plenty of data to support this. So patients who receive high doses of total body irradiation or who receive higher doses of chemotherapy as part of that conditioning regimen are at higher risk of developing graft versus host disease. But our prevention regimens, our GvHD prevention regimens, can be quite effective and offset that risk. And so, the physicians are always trying to weigh the risk benefits of the conditioning regimen with the GvHD prevention regimen, the prophylaxis.
Thank you. And are there risks associated with pregnancy and genital GvHD?
So risk of having a history of pregnancy, and then is there an association with genital GvHD? That's how I'm interpreting the question. And if that's the correct interpretation, the answer would be no.
What about if someone has GvHD, I get has genital GvHD, would there be a risk of becoming pregnant, like the other side of that?
A risk of, or can having genital GvHD increase or decrease the possibility of pregnancies? No one has looked at that. So when we talk about genital GvHD, apologize, that's my pager going off in the background. We talk about mainly the skin, sometimes the exterior skin along the vulva and the vaginal, having a rash, being quite irritable, dryness, tightness. Sometimes scar tissue can form within the vaginal canal, and some women need dilation of their vaginal canal to help loosen up some of that tissue.
Thank you.
And I'm just going to turn off that page.
Of course, sure. And just one final question, or actually request for a comment or guidance with this. If a post-transplant patient has symptoms of chronic GvHD, and they may be primarily seeing a primary care physician or a local physician who may not be familiar with the symptoms or familiar with treating chronic GvHD, what would you recommend to them as far as seeing a specialist, or who should they contact if they are concerned that they're not getting the attention or the care that they need for what may be chronic GvHD?
Yeah, that's a great question. So there are definitely resources available for patients to search for physician experts who have experience in managing chronic GvHD. So definitely asking your own doctor to look into who is available at transplant programs would be one option. And then there are some resources such as the BMT InfoNet. They keep a directory of physicians who manage chronic GvHD. And I know that there will be other directories available in the near future as well that will have a list of physicians who manage chronic GvHD.
Very good, thank you. And that's it for our questions today. Thank you, Dr. Lee, for sharing your time and expertise with all of us today.
Okay, thank you, everyone. Have a great day.
If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 38 years. This concludes today's program.